I think Dr. Revathi, Rajgopal, and another pretty face, I forgot the name.
Prapti Iengar.
Prapti Iengar. Okay. So they are going to be joining us, and they actually form the team of Psycho-Oncology of HCG. And right now, I think they're also trying to diversify into individual practice. I think they're forming an association or a separate organization. As we had a discussion last time, they are dealing with a very unique, very niche branch of psycho-oncology. I think last time we had a discussion about it to set the tone of what it exactly means. And we're going to take it forward. I think this is the first of the series of talks of 3 talks, followed by a workshop which Brinda has promised us, which is going to tell us to how to counsel parents, how to help them to cope up with the news and also the issues and perhaps even the terminal ill cases too. Over to you, Revathi.
Thank you.
All yours.
Thank you, Doctor. I'll just share my slide.
Yeah, while she's setting things up, Dr. Ramesh, actually, the Center of Psycho-Oncology for Education and Research was
Yes.
an initiation of, Government of India, Department of Science and Technology.
Okay.
The institution is nearly 12 years old now.
Oh, okay.
So it's not a new place. It's just that, the government had stopped funding, and that's how HCG was financially supporting us.
Okay.
And now to grow as an institution, we, it's an outsourced service for HCG, the psycho-oncology part. But at the same time, we're a standalone facility. Yeah.
Okay. Lovely.
You can start, Revathi.
Okay, ma'am. A very good morning to everyone. I'm Revathi Rajgopal. I work in the Department of Psycho-Oncology at COPA. In the previous presentation, Dr. Brinda had taken us through an overview on the evolution of pediatric psycho-oncology and also had spoken about briefly about the psychological issues or psychological odds that children and families undergo. In this presentation, I'll be talking a little deeper about the psychological impact of cancer in children and their families and how they place their odds at various junctures in the cancer trajectory. So I'll be talking a little about the epidemiology of the psychological problems in pediatric oncology, various aspects in psychosocial functioning, the common psychological comorbidities among children and families, and which is validated through evidence-based research assessments and standardized guidelines. So a child is said to be an uncut diamond who's raw and without any blemishes. Now, as a child goes through the various challenges of life, they get polished into a fully grown adult. Now, children are said to be the world's most valuable resource and the best hope for an optimistic future. But what happens when an illness like cancer strikes them? It could be devastating and could have debilitating effects on their overall well-being. Before actually talking about the psychological problems per se, I would like to throw some light on the magnitude, the psychological impact, or the magnitude that it has. 40% of children are seen to have at least one clinically significant psychological problem, and 10% of them report to have more than 3 psychological symptoms. There were various studies where parent proxy reports were considered, and this same thing was shown, wherein problems with regard to withdrawal, attention deficits, hyperactivity, anxiety, and problems with sleep were also significant issues that were seen to be among children. This graph here depicts the distress per symptom, and again, which reiterates the fact that sleep issues or problems with somatization seem to be the highest, followed by constipation, pain, nervousness, and so on. Therefore, the impact of pediatric oncology is psychosocially and is physically profound. Children with cancer, we understand, have multiple psychosocial issues, and therefore it requires a unique approach to conceptualize and operationalize their problems. Now, the significant domains of psychosocial functioning are as follows: physical, emotional, cognitive, and familial. So we see that these domains, though they appear to be discrete, but actually they are overlapping in nature. And this overlapping can be condensed within the context of developmental growth as well. The concept of these domains need to be understood with a little more flexibility among physicians and practitioners. For example, a patient who does not completely understand the physiological reality of the disease and treatment, for them the social context, for example the relationship with their families, peers, becomes vital or becomes more central. So generally the primary concern is the physical domain, because the extent of disease definitely determines the patient's overall level of functioning. For example, for a child with a hematological illness, the kind of physical impact that will have could vary in comparison to a child having an osteosarcoma requiring amputation. So, therefore, each disease carries with it its own meaning, fears, and treatments equally. There are various factors which affect psychosocial functioning. One of which being the disease site or the stage of disease. So the role that the part of the body has in affecting the disease, in terms of how the individual places oneself and understands himself and the environment around him, becomes very significant. As healthcare professionals, we must understand the value that each child attributes his or herself to a particular part of his or her body, because understanding this aspect will help us in assisting them through the psychosocial recovery, because we understand that cancer could have a negative impact on their overall well-being and in their developmental process as well, because it could be disruptive in the formation of their identity and could have a psychological impact on the self-esteem and thereby leading to psychological trauma. The other important aspect that affects psychosocial functioning is age. Now, within the arena of pediatric psychosocial oncology, there's a new age group which is developed, which is called the AYA, which is the adolescent and young adult population. And this age group has garnered a lot of clinical and research attention. But sadly, this age group is underrepresented because, as per NCCN guidelines, they define AYA population between 15 to 39 years of age at the age of diagnosis, which does not necessarily fit into the standard demographic profiling. So the AYA population needs to be given special attention and looked at in terms of a more phenological and developmental perspective, because studies have shown that adolescents, they have unmet needs even 5 years post completion of treatment. The other important aspect is the palliation or pediatric palliation, which is a very complex and a multifactorial aspect. The goals, as we know, of palliative care is to ameliorate symptoms and to improve quality of life. And the social state of a child with advanced disease could depend on various factors like symptom burden, medication effectiveness, familial responsibility or lack of responsibility, and so on. So the needs of the families and a child who's transitioning into an end of life care will be much different from a child having a treatable or a curative illness. So therefore, based on a clinical experience, we've seen that those requiring palliative support undergo a lot of psychosocial issues in terms of sleep-related functioning or pain, death anxiety, and so on, thereby increasing their psychological morbidity. So therefore, when we talk about the psychosocial functioning in palliative care, certain aspects needs to be considered. One, in terms of what is the child's or adolescent's understanding of a non-curable disease or a terminal disease or a life-limiting illness. And this will depend on their developmental stage. How a child transitions out of uh, towards end of life may be also affected by the family's level of function, understanding, awareness, distress, and comfort. One must also understand that whether the patient's disease and treatment process, the way it has been approached, again depends on factors which lies in the hands of the medical team in terms of how the medical team has approached the child or the family, in terms of the courage that is shown, honesty, and the medical integrity. All of these factors put together contributes to a quality of life / quality of death, a good quality of life, a quality of death. Now, let us understand with a little more clarity about what are the common psychological comorbidities that children and families undergo in pediatric oncology. In terms of anxiety, children with cancer are subjected to prolonged periods of time in hospitals, and thereby the normal life gets disrupted. So, understandably, parents also become anxious, and children are able to recognize this increased anxiety among their primary caregivers. So, anxiety can manifest at any stage of treatment, but often it is said to be intense in the beginning. So this at times can be experienced as refusal of treatment or procedures and so on. And some of the most common forms of anxiety that are seen are procedural anxiety or fear of procedures, which my colleague tomorrow will be talking about in more detail. But just to give an overview, this can develop when a newly diagnosed child with cancer has to undergo invasive procedures, for example, blood tests or biopsies and so on, which require frequent admissions or which must require frequent admissions to hospitals. So for a premorbidly anxious child, this can lead to extreme fear and fear towards hospitals and the medical staff. And they anticipate painful procedures. Therefore, children could also engage in panic behaviors when they have to travel towards hospitals. And commonly, they seem to cry inconsolably, or sometimes they could freeze during procedures. The other kind of anxiety which is seen as a generalized form, which is characterized by feeling worried or scared, irritability, difficulty in concentrating, clinging behavior, and so on. And adjustment disorders or adjustment related issues and mixed anxiety and depressive symptoms are other common forms of anxiety which can be observed. Now, when we talk about adjustment disorders, children and teens with cancer, they are able to comprehend the seriousness of the disease, and which basically contributes to increased distress at the time of diagnosis. So, additionally, they also become upset with various other aspects, for example, loss of contact with their peers or disruption in their school attendance or inability to attend school. So, academic functioning kind of reduces, and thereby they are unable to participate in the usual activities. This in turn could lead to in them displaying transient anxiety, mood fluctuations, mood symptoms, or even conduct related problems. But all of these symptoms are not enough to actually qualify for a diagnosis, a full blown diagnosis of anxiety or depression. For example, irritability, sadness may be observed before each hospital visit. Sleep and appetite issues may be disrupted for a few days, but these are subsyndromal symptoms which are seen, cannot be qualified for a full-blown episode of depression. And also, one important characteristic of adjustment disorder is that these symptoms will not exist if the stress of cancer would not have been present. So it requires a triggering factor. Depression is another significant psychological comorbidity which is observed. Some children who undergo treatment may present with social withdrawal, low mood, irritability, crying spells, psychomotor retardation, some of which could be suggestive of some subsyndromal depression also. So, as a clinician, while diagnosing patients with depression, we need to understand under what category do they fall, whether it's adjustment disorder or whether it's full-blown clinical depression. So some young people experience depression following a mutilating surgery or because of after effects of treatment, leading to alterations in the body image and so on. So therefore, if in the absence of RCTs or randomized controlled trials on depression in children, but there is enough of clinical evidence to show that the best form of treatment would be a combination of psychotropic medications and therapy. And one of which being cognitive behavioral technique, including relaxation, training, and cognitive restructuring are proven to be very effective among children along with family therapy. So there's a lot of research evidence to validate what was spoken about. Some studies have shown that 47% of parents have seen how their children feel grown apart because they feel very isolated from their friends. They're not able to gel with their peers. They feel separated because of being away from families or from school for a longer period of time. And 55% of parents of children have said that the child feel isolated, and feel neglected and left out when even when they stay in the when they stay in the hospital. It can be difficult for children to continue any kind of social activities with their family and friends, especially since they've spent so much time away from home, and this could lead to poorly developed interpersonal skills, feeling isolated, and thereby resulting in a low self-confidence and low self-esteem. Another significant psychological issue that often can be observed in clinical practice is agitation and behavioral difficulties. Now, one of the reasons for this could be the role of corticosteroids, which are vital in the treatment of many of the hematological illnesses like acute lymphoblastic leukemia. Um, Corticosteroids have medical benefits for sure, but it could also have certain psychological side effects such as increased restlessness and agitation. So it could cause changes in mood and cognition, ranging from changes in mood and cognition, and could also go up to children displaying psychotic symptoms. So changes in mood and cognition could mean in terms of showing irritability, emotional lability, pressured speech, and so on, and psychotic symptoms in terms of displaying or having features of delusions and hallucinations. So children with leukemia, they rarely exhibit self-injurious behavior, but in cases where they become extremely moody and aggressive, it could get displayed on, or they can displace that onto their primary caregivers. And acute agitation could become quite disruptive. Therefore, clinicians, pediatric oncologists must refer, patients in such situations to the psycho-oncology team. Again, the best form of therapy would be a combination of behavioral interventions and psychotropic medications. Treatment refusal is another important criteria wherein individuals or children need to be referred because it is considered to be an emergency. Uh, from a medical legal perspective, in most of the countries, before a medical treatment is commenced, definitely the consent from one of the parents is taken. However, in reality, a young person's cooperation needs to be there, especially when we're dealing with such chronic forms of illness or protracted forms of treatment. And it becomes very difficult otherwise to undertake procedures, for example, stem cell transplantation, or administer probably repeated cycles of chemotherapy against the will of the person. So, therefore, legally speaking, even though parental consent may be adequate and sufficient, nowadays many of the pediatric oncology teams document even assent from a young person in addition to parental consent when they treat adolescents with cancer. And there are certain guidelines that have been developed to address this treatment refusal in young people. One starting with rapport establishment with the child, and again, psycho-oncology team can be roped into this if they're familiar with the particular child who's seeking treatment in the hospital, and aspects which that, in terms of confidentiality that are neutral has to be discussed. Developmentally appropriate topics also have to be considered. At the same time, a child's mental state needs to be ascertained. If the refusal is related to depression or anxiety or any kind of psychiatric conditions, and if that is so, then psychiatric treatment needs to be initiated as soon as possible, followed by a risk assessment, which needs to be conducted. The context of the treatment refusal also needs to be established. We need to evaluate if the young person has specific fears which is associated with the treatment. And a common reason for this could be body image concerns associated with the chemotherapy, or it could be situational fear or anxiety, which may require a few days to reduce. So therefore, the pediatric oncology team and the psycho-oncology team will work hand in glove in a developmentally appropriate language and explain to a child in terms of what is the importance of the nature of treatment and the reason for why they need to go ahead with it in a way wherein it does not instill fear. So therefore, spending time discussing the treatment and addressing the fears must be the goal when it comes to addressing treatment refusal. Apart from the emotional concerns that children face, there are also neurodevelopmental challenges which individuals go through, especially the children who have a premorbid issue of an autism spectrum disorder or a significant developmental delay. So these children can become quite distressed even with routine medical procedures or day-to-day challenges in the hospital environment, or when they are subjected to very unfamiliar people. in terms of the medical team attending them. Could be nurses or doctors keep changing. So they are quite uncomfortable with people they're not familiar with. So therefore, in such situations, it would always be beneficial to provide them a little bit of a special accommodation in terms of probably a low stimulated environment or a single room or a picture schedule, where they're able to respond better to medical care which is delivered, and where a consistent team of nurses and doctors could be available. Children with neurodevelopmental disabilities often also struggle with abstract thinking. Therefore, medical education needs to be very precise and concrete, and this can be communicated with children in the form of photographs or drawings. And understandably, we'll be able to get across to the children in a much more effective manner rather than just verbal instructions. Another scenario where neurodevelopmental difficulties are seen are in cases where children with brain tumors, children have brain tumors. So cognitive consequences typically emerge in the first few years and could range again from mild to severe. Risk factors again could either be tumor-related characteristics or treatment-related variables, for example, the dose of radiation and so on, or individual variables, for example, the age of at the age at which they have been diagnosed. So some aspects of intelligence could be affected, or cognitive constructs could be more affected than others. For example, attention, processing speed, working memory, and so on, which could have a high impact in the post-treatment adaptation of the child. Various studies have been done to actually validate this. In 1990, Carson Green et al. Reported that children who belong to higher socioeconomic levels and children whose mothers had better coping strategies had better intellectual outcomes. There was another study done in 2012 that reported that academic underachievement was related to low levels of social support to family and high levels of conflict, stating that family and environmental factors also play an important role in contributing to aspects of uh, IQ or intellectual development in children. Now, how can it be evaluated? What is the assessment process? So, as per guidelines, there should be an initial evaluation and a post-treatment evaluation. And in the initial evaluation, premorbid development has to be assessed, taking into consideration the history and functioning. History of genetic disorders need to be documented. Need to understand whether a child has gone through any significant life event, any traumatic event, because again, this could affect their neuropsychological development. Education attainment, the kind of academic difficulties and strengths that they have, psychological risk factors, the type of family functioning, which is very, very important, the type of support, social support that is available, social factors, and the type of cancer, nature, location, and so on. Once that is done, post-treatment, again, that evaluation has also become significant because it helps us to determine the impact of that the treatment has had on the physical sequelae, example, whether if there's been a loss of vision or hemiparesis or any sensory deficits and so on. The treatment received so far has to be documented, the kind of educational engagement that they've had, cognitive problems, psychological symptoms, the kind of family functioning, whether it is a well-functioning family or a dysfunctional family, and changes in parenting styles. So some of it, there are different types of parenting styles, whether they've had a very authoritative kind of parenting style or a permissive one needs to be understood, and their current social circumstances. So all of it thereby contributes to their quality of life. Again, to assess quality of life, there are various standardized assessments and tools, and PETS-QL being one of the most significant ones, which has good psychometric properties, the Pediatric Quality of Life Inventory Tool, which is developed by Dr. James Burney. It measures the health-related quality of life of children and adolescents having acute and chronic health conditions. And again, it kind of evaluates domains which is physical, emotional, social, and school functioning. Substance misuse is another aspect or domain which needs to be considered because occasional experimentation, especially among adolescents, is seen with regard to alcohol and other substances. Even during survivorship, so during survivorship or even before treatment begins, habit history taking is very, very significant and very important. During the follow-up period for survivors, teenagers doing cancer treatment again must be routinely asked about the substance use and the misuse, because it could have serious implications during and following treatment. And during survivorship also, when they come up during follow-ups, they must be specifically asked whether they're engaging in any kind of high risk behaviors, including substance use. Body image is said to be another significant issue that many of the adolescents and teens face, and this could be as a result of an impact of the disease or side effects of treatment. Now, these body image issues need to be identified at earlier point in time, because if it continues to persist beyond cure, then it becomes problematic, and it becomes very hard for children to reintegrate back into normal life. So again, here the gold standard way of treating it is by ensuring that psychological treatment is received by them. We mustn't forget the role of a psychiatrist, especially in situations where it borders in terms of children having a post-traumatic stress disorder or developmental disorders, for example, ADHD or cerebral mutism and so on, because there the role of psychotropic medications also plays a role. So both the modalities, psychotherapy as well as pharmacotherapy, becomes very important for us, and its integration will help us to get better clinical outcomes. This is just a glimpse, a case scenario, which shows how a child, what are the kinds of thoughts that a child will hold when they go through psychosocial distress, and then how through adequate therapy they can overcome it. So the life of a 9-year-old, the thoughts that they often hold is, I want to walk, but I'm scared. What if I fall? My parents worry all the time. They usually hold my hands when I walk. Well, I'm not like the other kids, and I'll never again be like them. Uttered Ashwin, a 9-year-old boy diagnosed with medulloblastoma. So following surgery, he started having difficulties walking. He often lost his balance, and he had resumed his school recently post-treatment. However, he skipped school often. He preferred to often stay at home. He showed episodes of low mood, had decreased interest in his activities that he earlier used to enjoy, had resulting in dwindling self-confidence and self-esteem. So cognitive behavioral therapy was initiated to address these issues, and they had weekly sessions for 6 weeks. So in liaison with school, it helped Ashwin to experience a certain success in the academic front through positive reinforcement rewards. It was seen that how behavioral changes could be accomplished. And over time, Ashwin became less preoccupied with his walking difficulties and redirected his spare time into hobbies that required more cognitive stimulation, for example, playing chess and so on. So undoubtedly, cancer treatment has an impact across the lifespan development, and children go through 4 discrete stages of development from birth to adulthood, conceptualized as infant, toddler, or preschool, school age, and adolescence. And the impact of cancer treatment depends on the developmental stage in which the child is in. Now, as infants, it is the first year of life, and it's a very formative period, leading to a child's emotional development. This is a time where a child develops attachment, trust, and security with their in their relationship with their primary caregivers. Exposure to unfamiliar situations, pain, and disruption in the normal routine could actually pose as a psychosocial challenge. It can affect the infant's ability to actually achieve these developmental tasks. And they experience psychosocial challenges like difficulties in regular feeding, comfort, and so on. Cognitively also, it can be challenging to them and could kind of affect the sensory and motor abilities. Children usually they engage in a behavior which is called self-calming skills or self-soothing skills, by translating the experience that they have in their life into information, because this helps them to regulate their behaviors. But with when an illness such as cancer strikes, or the ability to self-soothe, etc., kind of reduces. The next stage of development is a preschool stage, where a child between the years of 3 to 5 years could also face a lot of challenges. So cognitive development is mainly characterized in this stage, where a child's imagination increases, they engage in something called magical thinking. For them, they contribute more to understanding concepts in terms of causality, and by providing simple and consistent explanation about the illness and treatment is something that is recommended. For example, providing factual information about the name of the illness. For example, you have a sickness called leukemia, which is why you're feeling so tired. So you need to stay in hospital so that you can get a special medicine called chemotherapy to make the leukemia go away. So these are ways in which the explanation can be initiated about the kind of illness that they have. Cognitive challenges definitely are present. Behaviorally also, this is a time where a lot of temper tantrums and resistance can be. Now, as a child goes to the next stage, which is the school age, between the age of 6 to 11 years, it is seen that a lot of disruption in terms of, because school is a very important, school plays a very active role in this period where there's a lot of cognitive stimulation, a lot of emotional growth. And this is a time where they establish a lot of social relationships with their peers and so on. And this is a time when children become aware of themselves. They develop the capacity to think logically and to be able to differentiate between them and the world outside. But because of certain cognitive challenges, their concrete understanding could get diminished. They could develop frequently aversion to medicine, and so on. Now, as a child from childhood now transitions into an adolescent phase between the ages of 12 to 18 years, this is so adolescent phase is said to be the hallmark of adolescence is said to be the search for identity. This is a time where even in the upcoming slides where we'll talk about Erikson's theory about the psychosocial stages of development, we'll see how one of the main challenges that adolescents go through is confusion between identity and role confusion. They are unable to understand, so constant questions such as who am I, what is my identity, is something that they kind of struggle with. And there's a lot of role confusion that they experience, especially post-treatment when they have to reintegrate back into a school environment. Many of the times they face rejection from peers, leading to depression. This is cognitively, their abstract thinking, theoretical concepts are developed, but because of certain challenges that they face, treatment-wise, this could take a backseat. Risk-taking and non-adherence is another kind of behavioral thing that they engage in. So, therefore, all of these, stages can be substantiated with a theory by a theorist called Erik Erikson, where he talked about the various stages of psychosocial development that a child goes through from childhood, as being an adult, from being an adult to as they go through the various stages. So during the first year of life, the challenge which infants go through is the concept of trust versus mistrust, which again, if children are consistently provided all the basic needs, for example, food or warmth or love or affection, they will be able to trust other people. And the concept that children understand is that the world is good. So that is a favorable outcome. They learn to trust the world. But in situations where, for example, they are unable to achieve this kind of an outcome, especially when they are when cancer strikes them, it leads to them becoming insecure, and it causes suspicion in them. They're not able to trust another individual. As they move to the second year of life, the next challenge which they encounter is autonomy versus doubt. So when children are autonomous, they feel independent. They feel they can make their independent choices and decisions in whatever small ways. If caregivers are supportive, children will and are given that self space to grow. They will be able to develop their problem solving skills as well without any kind of demoralizing or ridiculing, etc. But if that is not done, then children can be subjected to shame and doubt, and they believe that they're not able to make valid decisions, and thereby stunting their self-esteem as well. Now, as a child goes through the next stage, the other challenge they encounter is initiative versus guilt. So, as children develop initiative, they continue to develop themselves, or the concept of self-development or self-concept increases. They try new things, they experiment with a lot of aspects, and they feel that they're responsible for their actions. And if children are given that safe space to grow, then they will be able to find their purpose as well. in situations where it is not possible, where there are strict boundaries which are enforced, too much responsibility put on them, the aspect of guilt can set in, which takes away their sense of independence, autonomy, and they feel guilty that they are unable to perform a complete task perfectly. And the next phase as they go through is industry versus inferiority. This is before when the child is between the years of 6 years up till puberty. This is a time where a child understands how things work and how to organize themselves and things around them. But for example, if they're not able to achieve that outcome, it leads to inferiority and a sense and also self-doubt and so on. So these are the stages of childhood. Now, as the child transitions into adolescence, like we said previously, identity versus confusion or role confusion is the challenge that they encounter. And they experience unique developmental challenges of autonomy, independence, peer development, education, issues with intimacy, fertility, and so on. If they are able to achieve the outcome with proper family support and things like that, they are able to see themselves as unique, independent. Apart from psychological problems that children encounter during treatment, there are also a lot
Hi,
of
sorry, I lost the audio completely.
effects that are seen during survival.
I tried to do that. Let me just leave the meeting again.
Um, studies 50 to 60% of hello. Hello.
Yeah, I can hear you. You can continue, please.
Okay, sir.
See, 1 second, let me just check.
Brinda, I suggest you restart. Just rejoin.
I'm hearing from your phone. I'm not able to hear from.
I'll talk to Brinda on phone. Revathi, I think you can continue. Let's continue, please.
Okay, sir. Okay, sir. Okay. The studies have shown that 50 to 60% of childhood cancer survivors are at risk for cognitive impairment, and the areas of cognitive functioning that get affected mainly are attention, concentration, memory, language, various executive function, visual perceptual skills, and processing speed. Various CNS related malignancies or can lead to neurocognitive outcomes, which suggests that we need to have a proper full-fledged assessment of the neuropsychological assessment and a routine monitoring by mental health professionals who are trained in neuropsychological testing. Target aspects should be school performance or when they identify certain changes in their attention span or visual motor coordination, concentration, memory, and so on. Annual academic testing should also be conducted. So having a neuropsychologist or having a partnership with psychologists who can facilitate this in other hospitals could help us get timely evaluation and will help us get better outcomes as well.
Ma'am, your slides are not shared.
Oh no. Sorry. Is it visible?
Yes, ma'am. Visible. Go on.
Yeah. Okay, thanks. So, who qualifies or who needs neuropsychological testing? especially individuals having tumors of the central nervous system where they're subjected to undergo cranial radiation, or those with hematological illnesses wherein they are subjected to intrathecal chemotherapy or higher dose of methotrexate during the consolidation phase, have neurocognitive changes. Total body radiation is another area where if a child or an adolescent goes through, will be necessary that their neuropsychological well-being is also evaluated. Now, prolonged hospitalizations because of treatment and side effects could have an impact on the overall functioning. Therefore, pediatric oncologists, if they're able to identify specific concerns, especially during follow-up visits, etc., in terms of if there is a decline in a child's school performance, or there are certain changes that they observe in their learning or development, they must recommend neuropsychological testing, and this is also being validated by certain international guidelines. Now, it's important to address the issues that we spoke about in a more holistic manner. Therefore, individual psychological treatment is one of the modalities that can be subjected to. It can be divided into two categories. One is behavioral management and one is cognitive behavioral therapy or strategies. Children, behavioral strategies are a little more feasible, and adolescents and co-related to adaptive models of CBT. Various other techniques that could be facilitated could be administering thought diaries for them, training them in progressive muscle relaxation or positive self-talk. Along with psychotherapy, pharmacotherapy also plays a very important role. Psychotropic medications will be useful in situations where anxiety related or mood related disturbances is observed in children and adolescents, and it's important to know about the symptoms of cancer and the side effects of the chemotherapeutic agents, so that the medications, psychiatric medications if prescribed, can be titrated adequately, and the possible drug interactions must be known before administering them or subjecting them to any kind of psychiatric interventions. And the common antidepressants that are generally used are SSRIs, which inhibitors such as fluoxetine or escitalopram. So not only on children, the psychological impact can be seen on families as well. Studies have shown how carers or parents have reported feeling lonely and isolated following a child's diagnosis. And 79% of them, they have felt completely of being overwhelmed or a sense of grief at the loss of a normal. Hello?
Huh?
Hello?
You have to mute your mic. Brinda, can you hear us? Brinda, okay, I think I have to continue, please.
Sir, I am audible, right, sir?
Yes, ma'am, you're audible.
Okay.
Please continue.
Okay, thanks. Parents also experience issues in terms of coping along with stress and anxiety. A study has shown that 50% of parents have said that because of lack of information in terms of ability to cope with the emotional distress or talk a diagnosis, it has been very difficult for them to carry on or to concentrate on the treatment of the children, and they were subjected to high risk of psychological morbidity. There are various research evidences to kind of validate this aspect. This was a study which is published in the Indian Journal of Palliative Care, a cross-sectional study where it revealed that high levels of anxiety among parents of children with cancer was seen. 42% of parents displayed clinical symptoms of anxiety, and 35% of them showed depression, features of depression. Another research article, a very interesting article, also spoke about the role that family functioning has in terms of how different members of the family view an illness and how they cope with a child's treatment and so on. There is a assessment or a tool which is called the FES, the Family Assessment scale where they talk about 3 domains of family functioning. One is in terms of cohesiveness, second communication, and conflict resolution. So all of these aspects are very important to be understood even from an evaluation perspective. Now, not only children, so families also need to be looked after. Their well-being needs to be taken care of. And how can that be done? So there are various strategies and approaches. Starting with a family session could be ideal. So one important thing that has to be communicated is that family, professionals, and the young person are all on the same page. They're all on one side trying to deal with the cancer. And families need to be encouraged to continue their being a close knit unit, and they must be, if families hold any kinds of myths and misconceptions about illness or treatment, this is a good opportunity where it can be dispelled. Now, in situations where families are extremely anxious, a formal family therapy is recommended. It will be very beneficial, and because they'll be subjected to multiple sessions of a structured approach wherein the psychosocial issues can be dealt with adequately. Now, this is a case scenario where it shows the importance of a family kind of involvement. So this is a mother who wanted her child to eat fruit. An 8-year-old was diagnosed with acute lymphocytic leukemia, who was admitted to the pediatric oncology ward. Nurses noticed that his mouth was often full of food. The staff soon discovered that the mother believed that eating pomegranate would actually replenish red blood cells. So the child, because of which the mother became quite overtly obsessive about this fact and fixated on the fact that pomegranate has to be fed. In turn, what happened was the child hated or started detesting pomegranate completely and started keeping the food in his mouth and avoided swallowing it. So clinicians, they were very worried because it would obviously lead to poor oral hygiene or subject him to viral infections. So, as per nursing instructions, a referral was given to the Psycho-Oncology team, and after proper psychosocial assessment, family therapy was offered to the family. And in this, it was discovered that the mother overtly emphasized the importance of eating because she had very little control over the other aspects. So, what she could control was the diet part, and because of that, she became very fixated over it. So, over time, she was able to understand that it's not only child's diet which is important, but we need to see the larger picture as well. The psychological impact is not only on children or not only on the child who's having the cancer or on the families, but it's also on the siblings as well. So undoubtedly, parents often tend to give more importance and focus on this, thereby neglecting siblings. And often siblings, they feel angry and resentful due to the same. So clinicians working with families must encourage that siblings also should be part of the treatment process, decision making, and caregivers need to be reminded that adequate time needs to be allocated for healthy siblings as well, because otherwise it could cause friction between the siblings, it could cause sibling rivalry and so on. Siblings also experience psychological morbidity, for example, post-traumatic stress symptoms, or increased negative emotions and a poor quality of life in emotional, family, and social domains. So therefore, there are adequate standards to understand the psychosocial care for children with cancer and their families. So with systematic assessment of their needs during treatment and survivorship must be facilitated. High-risk patients should be identified. Red flags must be put down. For in those situations, routinely, neuropsychological deficits should be monitored. They must youth and family must also be given the opportunity to access psychosocial interventions and psychiatry also if required. And if they are able to receive developmentally appropriate transition, even at a curative intent, or whether even if the transition to an end of life care state or during bereavement support, this would be beneficial. So therefore, a healthcare team approach to the treatment of psychosocial concerns initially was unimodal, then moved on to multimodal form of treatment, multidisciplinary, and now the emphasis that is being given is an interdisciplinary form of treatment that has to be incorporated, wherein not only the treating oncologist, but various other specialty for example, the pain management, the physical rehab team, the nutritionist, the psycho-oncology team, all put together will be able to facilitate better clinical outcomes. So to conclude, it's important to understand that psychosocial assessment should be included in various diagnostics and clinical outcome assessments. And if failing to do so, it could lead in a very incomplete and very sketchy understanding or condition of the child. It will only be physical. It will not be biopsychosocial, because that is the current model that is practiced, which is the biopsychosocial model. Therefore, we need to be aware of the comorbid psychiatric illnesses and identify appropriate healthcare support services, which will be able to assess this transition in a more effective manner. So, therefore, sometimes real superheroes live in the hearts of small children fighting big battles. And just like Sir William Osler stated, that a good physician treats the disease, but a great physician would always treat the patient who has the disease. So I conclude my presentation with this thought. Thank you.
Thank you, Revathi. It is quite an exhaustive talk and actually highlights about how many things we actually don't know. Thank you very much.
Thank you, sir.
Information is sort of difficult to comprehend everything. So, but I will definitely ask Dr. Brinda to sum up and highlight the important things that Dr. Revathi spoke. Brinda? Brinda, am I audible? Brinda? Okay, technical issue. Yeah, Brinda.
I'm supposed to respond when
Brinda, we can hear you. Okay, I'll speak to Brinda personally on phone. In the meantime, Prapti or Ramchandra sir or anybody else, please take up the discussion. I'll just talk to her and fix it.
Dr. Revathi, that was a very nice, very detailed talk. I'm Dr. Ramchandra here. Thank you very much for this talk. Thank you very much for this talk. So I wanted to know, are there any studies coming out of major institutions like say Kidwai or Tata Memorial or such similar institutions in India, which talk about specifically focus on pediatric psychosocial, psycho-oncological work being done in these institutions? Because their numbers are huge, and are they addressing this issue in these centers like Tata Memorial, Kidwai, and such similar centers like Adyar in Chennai or RCC in Trivandrum? Are they having any studies being done? Have they come out with any publications? Or are there units dedicated to, at least partly dedicated to pediatric psycho-oncology, especially when it comes to treatment of small babies, small children?
Yes, sir. So like I mentioned in my presentation, randomized control trials or studies such as that are not yet present, especially when it comes to addressing the psychosocial issues in general. So pediatric oncology is even more specific. So even when I browsed through a lot of literature, it was more of global statistics and figures that I found, and very less clinical data from India that I could actually kind of figure out. I had been part of training program which is called Credo, where they help us develop research protocols. I had attended in March. So there I had been exposed to a few protocols and proposals wherein it's especially in Tata Memorial, where I think a girl from the palliative care department, she had brought in a proposal of trying to create an RCT wherein aspects of anxiety, depression, all of this can be evaluated among pediatric patients. But I don't know whether the study is taken off or whether she's able to actually execute it. But I had told her that we could always collaborate and work on it because data is limited. And it's not that we don't have content, or it's not that we don't have data. We have enough of material, but it's only in terms of materializing it. So I think with appropriate steps, we should be in time be able to produce good research studies in this area. But right now it is limited. I agree.
Yeah, thank you.
I think Dr. Brinda Sitaram wants to speak something, but I think she has some technical glitches. She's taking the help of her nephew. So Iengar should sort out the issue.
Now I'm able to hear. I think the problem is sorted.
Yes, please, Brinda.
Yeah. I lost Revathi's presentation quite a bit. I think the last 10 minutes, I couldn't hear anything.
Don't worry, the top information. I would like you to just summarize what all you think should have been covered. So in case it will go on to add on to whatever Dr. Revathi has already spoken.
Hello? Can you hear me?
Yes,
I can hear you.
Yes, ma'am.
Yeah, there was some interruption when Dr. Ramesh was asking me something. So do you mind repeating so that will help me to kind of respond?
No, basically we wanted you to give some of your input because she gave a very, very, very good talk. As I told, it was very exhaustive and quite illuminating because she highlighted on things which we did not really know much. I mean, we knew vaguely existed, but we were able to articulate. She articulated fairly well. I just wanted you to just add whatever you would like to add.
Yeah, I think what I would like to do is, summarize. But I think in a nutshell, it's very important to understand the psychological impact to a large extent is given, be it an infant, a toddler, or a young adolescent. But what is very challenging is that very often when particularly the young ones try to kind of, express their distress because they're not able to articulate very eloquently as young adults or we adults do, it becomes very challenging because much of it is behavioral. And even in young adults, it's very well known that under trauma, they get into regressive behaviors. There could be lots and lots of behavioral problems and so on. And much of it is also because what happens is that is where the premorbid history is very important because, the parental styles are very important. What kind of disciplinary measures were being taken is very, very important. Alongside is also the fact when the child is ill, the chances are people give in. And invariably, there is multiple parenting that goes on. So children, to a large extent, I mean, as human race, I'm sure it's there even in the animal kingdom, we are by nature very manipulative. And more so in children, they're extremely manipulative. And the way they test the environment is through their behavior. And very often what we notice is that, parents or even the doctors telling us that, children are not cooperative, they're very abusive at times, they're using foul language and stuff like that, which is very well known in a clinical kind of context. But oftentimes what happens is it is kind of reinforced by a whole lot of people in the environment, including the medical team, because we are very afraid to kind of be firm with the child because sometimes parents don't like it, or the parents don't want to be firm because to some extent they could also be going through some guilt because I've had instances in a session where parents tell me that we were very strict with him and maybe that's the reason why the child is unwell today, or they're going through their own psychological trauma at that point. So they just want to give in to the child because they don't want to deal with any kind of misbehavior or regressive behavior and so on. Much of the work with the child is actually with the parents. It's very, very important to engage largely with parents. And I think, at a point where I lost Revathi is that she was talking about cognitive behavior and so on. I think, see, these kind of therapies are again age related. we can't be doing cognitive behavior therapy with, children who are very, very young. So with young children, we engage in a lot of behavior therapy or behavioral techniques. That is primarily the predominant therapy that is used is play therapy. Very often children try to project and displace their emotions via play or the game, as it were. And even in normal circumstances, we see children. I think tomorrow I'm presenting the video, and I think even in my last talk I did talk about a child where I had to prepare this 5-year-old for hair loss and so on. What she would do is she would go home, and for her Barbie doll she would do this quote unquote light therapy, which is radiation treatment, because that is what I had called radiation, to help her understand that it is like a light treatment. And she would go pull out the hair of the Barbie doll because she was prepared for going bald post radiation or during radiation. So what I'm trying to tell is that I think it's very important, first of all, to understand the developmental stage of the child. 2, the premorbid levels of functioning, both intellectually as well as emotionally, before we plan out any treatment. And majorly what is important is engaging with parents. And in an Indian kind of setting, very often it is also, extended families such as grandparents and so on. So they also have to be roped into the therapy platform if we have to bring about any desirable results with the child.
Okay. Brinda as well as Revathi. What you highlighted was fantastic, because whatever you said about children's reluctance, not accepting, moody behavior, depression, we have noticed it. It is not that we have not noticed it, but unfortunately we don't know how to handle it. So most of the times it's like what Brinda said about multiple parenting. We just force our way, just say or cajole or just bribe them. I mean, what can be done at a simple level? It is ideal to have a psycho-oncologist to come and see it, but it is not practical, especially in a setup large volume centers like Kidwai or Indira Gandhi. It is difficult. So is there something, simple tips and tricks that you can give us?
Revathi, you want to respond?
Ma'am, you can respond, ma'am.
For things that I would like to bring into focus is that, first of all, Dr. Ramesh, it's very, very important. I'm sure as physicians you all do this, but for us, when the referral comes, is first to rule out the organicity, whether there is any organic problem. When we talk about organic, not just of metastatic disease alone, but also of chemical, interplay. Like she mentioned about the steroids. Sometimes it could be electrolyte imbalances and so on. Once we have ruled these possibilities out, only then we start to engage them in any kind of psychological therapies, as it were. I think to some extent, Prapti's talk tomorrow would kind of touch upon how exactly to approach these children, coming up with various problems for you clinically. And like you mentioned in the very beginning, we are planning a workshop for for all of you to kind of understand some of the clinical tips, as it were, in terms of, first of all, how to engage with these children, how to engage with these families. And like you rightly said, you're able to identify the problem, but how to troubleshoot those problems. I'm sure Prapti is going to talk about it tomorrow, but for example, toddlers and so on. Even simple things like a white coat can be a huge barrier that can set off an emotional reaction. And once the child is exposed to a very stressful environment, in fact, incidentally, that is our challenge. By the time the child is sent to us, for example, the child probably has already gone through surgery and, sent for radiation to a kind of setting. In the radiation unit, the child is posing lots of challenges and we get involved. See, all of us are seen as potentially very threatening for the child. So therefore, the child does not build a relationship with us. So I think it's very important even to look at some of the cues. For example, like I said, the white coat. 2, when we talk about rapport building with young children, invariably rapport building is touch, or, to get down to their level, bring about, actually help the child in us to kind of really come to the fore. Once we start behaving like them, the chances are, they start to become a little more friendly and so on. So the initial contact is very, very important because that is the moment of truth for the child. So that first contact must be a very neutral kind of environment, as much as possible, not to keep them in a very overwhelming clinical kind of a setting. Perhaps, even in your setting, if you could kind of just earmark a play area or a play pen or something, and doctors can kind of visit these children in that play environment, the chances are the child will start to kind of feel a little more secure and safe, and the chances are, they will start relating to you a lot better than they would do in a typically clinical context where, there is a standard cot and, the step and the injection syringe and stuff like that. So some of these things can kind of neutralize and buffer the emotional distress of the child.
Okay. Now, in fact, I would like to shift the focus to the residents in our department. Okay, Vinupriya, Vandana, and all these people. I mean, you've been seeing these patients when they come. In fact, you are the ones who are spending maximum time with them. Even though we are there as consultants, come and take decisions and go, but it is you guys who spend more time with them. What sort of issues actually you do face with them, Vinu and Vandana, and who is there? I want you to just highlight about the things the issues that you come across. Unfortunately, Pooja had to leave because she had some other personal issues, so she couldn't continue. So I'd be happy if the residents know out with saying what sort of they face.
We have two sets of children. One is already who have been diagnosed in KidBi and who come from KidBi for a definitive procedure or some kind of procedure. Those kids are quite fine. Like they're not scared. They're well aware of all the procedures or IV cannulation or anything. But problem comes when they come with the disease primarily to us. One thing is with related to child, definitely that anxiety, that clinging on to parents not cooperative, all that issues are there. One more is parents. What we find is we find it very difficult to actually break the news once we get to know it's a carcinoma or prognosis is bad. All such things. These are the issues we face.
Yeah, just to respond to you, Dr. Vandana, in fact, that is what we are doing. I think day after tomorrow, my talk would kind of just give you a theoretical orientation to how to really kind of break the bad news and so on. And eventually, we are planning a workshop where it is like a hands-on kind of role play, and demos would be kind of, we're planning a lot of demos to help each one of you understand, and I think it's a good exercise for us as well to help us kind of facilitate, some of these clinical challenges that we all encounter in terms of how to break the bad news. Very often we believe that they really don't know the bad news. The truth of the matter is they already know, including children. They're able to kind of, comprehend their context in their own way. They probably will not be using words such as cancer or carcinoma, but they know that they're unwell. They know that there's something not right about them. They know that, they're kind of being exposed to these, medical kind of facilities. So deep down, they understand that things are not okay with them. Things are not normal. Coming to the parents, they definitely, if they're educated, they of course read whatever is around them. And of course, now there is always Dr. Google to help them out. But that apart, even with illiterate population, they know that it is kind of a serious condition. It is not as simple as they originally believed it was, and so on. So some of these things actually I'll be touching upon in my talk, how to explore what they really know, and then how to kind of, engage them in a conversation to kind of, break this news to them.
Thank you very much, Brinda. I think it gives us a fodder to look forward to something new. We have all been handling our own, but we'll be happy to have it in a structured manner, in a fairly objective, and it can be measured. We'll be happy. Vandana, Vinupriya, Ravni, any questions or suggestions? Otherwise, we'll wind up.